and 5.
4,
3, 2.
1.
So Nick first, then Krista. It is May 21st, 2025. Welcome to this edition of STED Talks Spine Technology Education, and the D stands, as you know, for Discovery, Discussion, Discourse. And I'm wearing a new look. Hey, Meta, record this. Got it. Who is our visiting professor today? Can you recognize that, Meta? Hey, Meta, record this man. This is Dr. Sigurd Berven. It is such an honor to have him here. There's a buzz in this room. Thank you so much for our colleague to come up here. We have our great colleagues from Tacoma here also. So this is a great atmosphere. And I thank Dr. Oskuyan for lending me his glasses so I can take a really close look. Hey, Meta, record this. So cool to see you here in person, live, a larger-than-life person, Dr. Sigurd Berven, one of the absolutely leading figures in spinal deformity surgery and beyond. And he's coming here from UCSF. I'll introduce him in greater detail later, but he's going to talk about some new advances in how to make fusions more predictable and accurate. And as always, Dr. Berven, and without any curveballs, we have not 4, but 5 cases for you. And just for you, we have a visitor from Chile here, from Santiago de Chile, Dr. Castillo. But to start things off, Dr. Nick Minisali, who's again wearing his Philly Eagles. Meta, turn the recording off. He's wearing his Philly Eagles outfit again, but that's okay. The Patriots shall rise again. But he has 2 cases, and he's going to do them relatively quickly. As always, your comments will be much appreciated.
Terrific.
Nick.
Thank you. I had to bring the lanyard back just to prove I didn't jump ship for the Eagles here. All right, so I do have 2 cases. The first one's mid-60s-year-old male with bilateral hip and back pain, muscle spasms, as well as numbness and tingling into bilateral extremities in approximately the L5 dermatome. He does have a history of prostate cancer back in 2017 that was treated with chemoradiation as well as prostatectomy. He's had multiple lumbar spine surgeries. Based on available information and imaging, we were able to identify 2-level lateral lumbar interbody fusion. That was 2017 in an outside institution, and then a MIS L4 to S1 fusion in 2018 with 2 revisions thereafter. He does have significant left lower extremity weakness with ankle, plantar, and dorsiflexion, as well as EHL, and some mechanical pain and trouble with the knee flexor as well. So here are our clinic films from his first time visiting us. You can see the AP and lateral lumbar films with a combination of L2 to S1 fusion construct. You can see between L3 and 4, there's not continuation of the rods. I don't believe this is broken. I believe this is the construct that was implemented. And you can see this posteriorly displaced cage at L5 S1, as well as lysis around the S1 screws.
Dr. Minisali, how many surgeries again, total, best estimate, lumbar spine?
I think 4.
4. Dr. Berven, before we go into the obvious, and again, today's main topic is cages, and we could add to that what the heck happened here at L5S1. What are your thoughts when you see a construct like this, just in principle, discontiguous rods, alignment, MIS dedication?
Yeah, so as Nick, right? Mm-hmm. As Nick was going through the history, with 5 total surgeries from 2017, started off with a fracture that was the L2-3 and L3-4 interbodies, and it'd be interesting to see the sequence of how this built up. But when I see a film like this, the first thing I think of is this is something that was done piecemeal at an ASC. So in this case, it sounds like the history was a little different. There was maybe some trauma involved. But the first thing I think about is if I were to do my surgery in an ASC, then I would probably do maybe a 2-level direct lateral, maybe I'd do a TLIF at 5-1, and then sort of piecing things together without necessarily seeing the overall picture. And I think this is sort of one of my major criticisms sometimes of MIS surgery is number one, the lack of lordosis from L4 to S1, right? The poor distribution of lordosis. And number two, the notion that there's piecemeal, you sort of attack a part of the spine, but don't think about the spine as an integrated unit. And we see a lot of this. And you asked me what I think about it, is I think this is something that was sort of where it was attacked piecemeal rather than as an integrated unit.
Well said. Now to the obvious question, do you have further imaging studies
Yes.
to illustrate what's going on? So the obvious concern is now what happened at L5S1, aside from the discontiguous ASC-delivered MIS procedures, which, if you look at it cumulatively, 5 surgeries is not MIS anymore, right?
Yeah. Yeah, at some point, the cumulative effect, the cumulative burden of this person's surgical load is this is no longer MIS. So this is interesting here. I think it'd be interesting to know the time course of when this interbody device, was this an acute presentation where?
To our clinic, no, I think it was about a year out.
Yeah.
Or not quite, less than a year, 6 months.
And I'm almost a little bit surprised to see that the neural deficit was as mild as it is. You said maybe some dysesthesias, some sensory deficit to L5, not much of a motor deficit. I thought if I saw the exam, it's actually more just hamstrings, you said, right? Or knee flexors.
It was ankle dorsiflexion, plantar flexion, about 3 and 4s. So
Okay, so
somewhat of a disability, yeah.
a foot drop.
We
Okay.
did have hip abduction weakness, which we did not list here.
Yeah, so typical of an L5 type of a deficit is. So this is something that I think clearly displacement of the cage, loosening of the implants, and this is something I'd actually have a pretty high degree of suspicion for maybe there being an infection as well with this degree of osteolysis. This is one where intraoperatively I'm virtually always going to actually take cultures on this, and I'd have a real high suspicion that some of those cultures would be positive.
So there's a strong, first of all, L5S1, is this a surprise? Why L5S1? What do we make of the S1 screws? Is this just a mechanical ill effect? Could this have been avoided by doing ALS screws or iliac screws?
So, one of the things we think about, and it's maybe for fellows as well, is I ask a lot, is when is a fusion a long fusion? And I think Brian Cunningham, biomechanically, really demonstrated that when you get above L3, really L2 to S1, that the strain on the S1 screws becomes significantly higher. So long fusion, and this gets into question, when do we think about pelvic fixation? A long fusion, I think about anything above L3 down to the pelvis. And in this instance, this is going to put more strain on the S1 screws. So virtually always, even though this is discontiguous, effectively this is an L2 to S1 fusion. And in these instances, one of the things I'd be thinking about is adding pelvic fixation. I think in the absence of pelvic fixation, this is what you're perhaps at risk for, is loosening those S1 screws. And I think it's interesting, in my practice, I use very little navigation in these kind of cases, but I'll actually use fluoro intraoperatively. My workflow is quite specific, and I tend to freehand all of my screws, except for my UIV. If I'm cementing it, I'll have fluoro to look at the cement, and my S1 screws. And I'll fluoro to make sure I really get up into what I call the tricortical point there. So really the intersection between the end plate of S1 and that anterior cortex, and the insertional torque really goes up dramatically when you get up through that anterior cortex. This, where the tips of these screws are, is just pure cancellous bone. So the absence of pelvic fixation here, which takes strain off the S1 screws, right? That's why we use pelvic fixation to take strain off of S1, and the screw tips being in that cancellous bone. This was already at high risk of a failure, I think.
So we're going to talk about some sophisticated new cages, and again, we can't thank you enough for coming in person today. This was an expandable titanium cage. I don't see much lordosis here. Should be about 20, 25 degrees. L5S1 right, 22 degrees. So what happened? Did this not expand fully? Was this a technical failure? Was there a surgeon lapse? What happened to this expandable cage that did not fully expand and that it could slide out like this?
You know, you taught me about intradiscal osteotomies, and you really had some terrific experience with being able to mobilize that intervertebral space from a posterior approach. And I do a lot of anterior work, but at the same time, we both been able to really mobilize segments from posterior, and it takes a lot of work. And I think that in a lot of instances, especially if you're trying to do this MIS, you really got to take down the facet joints. So to mobilize between L5 and S1, you really got to, most of that is actually releases. And the cage, you can't rely on your cage to really get that kind of mobility. And I think that this is probably something where there was an inadequate release. You sort of see the end plate of S1. Was that something where the cage might have actually dug into or subsided a little bit?
Yeah.
I think so,
And then
yeah.
with the osteolysis, again, I've got a bit of a suspicion that there might be some infection here. That might have been where the cage would migrate. I would think that an expandable cage would be less likely to displace posteriorly than a non-expandable cage. But why didn't it expand? I think it probably wasn't an adequate release.
I think so too. So we want to move on because we have 5 cases today, but these are valuable insights. And the key point, I think, for all of us is whenever you see osteolysis, you have to think about at least an opportunistic infection and be prepared to draw and take out adequate cultures and be prepared to have an extra long surveillance time in case it's PQD. So those are some main thoughts.
And Jens, I'll add a key point, because this will come up later. A key point is also the notion of look at the absence of lordosis from 4 to 1. Is if you look at a standing film, when you see L4 being kyphotic, that's sort of a gestalt that without making any measurements at all, you know that there's been a lack of lordosis from 4 to 1. So trying to get 4 parallel to the floor, and in this instance, I would imagine that where we want 35 degrees lordosis from 4 to 1, there's probably certainly less than 20 degrees there.
Now, you're an anterior guy also. Usually we would take non-unions at L5S1 with interbody cages out from the front, but I think there's a little question to go in from the back here, correct?
Oh, I think to take this out would be tough to do from front.
Yeah.
So you'd be fishing around. So I would take this out from the back. And in this instance, one of the things that's a challenge is how are we going to reconstruct that 5-1 and get lordosis back? And I think you've got to start from the back, because if you tried to put something in from the front, you'd make this worse. It's pretty rare that I do a front-back type of surgery. So in my hands, I would do this from the back and really work on that disc space, try and release that L5S1, and I'd probably try and reconstruct this from the back. Although I think I would do a better job with an A-lift, meaning taking it out from the back, going in with an A-lift, and then going back to the back. And that's something certainly we have done. But I might try and, with the work that you've shown me, and I've done quite a few of these now too, is I might try and work in the interdiscal space and try and reconstruct this from the back and get it done in one stage. Definitely add pelvic fixation and definitely make the rods contiguous.
Drum roll, move forward.
Perfect. So
We had a
that's
great
exactly
discussion
what
here.
we did. We did removal of the posterior segmental hardware, L2 to S1, and debrided the screw tracks at S1. Did revision laminectomy, L4 to S1, and wide neurolysis at L5 and S1 nerve roots. Found significant scar there. Removed the
No dural tear. No dural tear.
Yeah, correct. Yeah. Removed the displaced cage and performed the intradiscal osteotomies at L5S1 with bilateral cages and local bone graft, and then did revision posterior fixation to the pelvis.
And quad rods.
With quad rods,
L5S1
yes.
screws,
Yeah.
and then a long spanning rod.
Yeah, I think getting as big of a footprint as you can. So you have two interbody cages, trying to find some decent end plate bone, because the end plates here aren't going to allow you to push hard on the end plates. So this correction was gotten with the release, and then the cages kind of filled the space
And held it, yeah.
rather than actually trying to push against the end plates, right?
Yeah.
Rod, we're going to show a case that we did together. You're one of the avowed masters of X-lifts. Now, I don't see you doing a lot of X-lifts anymore, at least not in the lower lumbar spine. What are your thoughts on X-lifts at L4-5, and how could they get an X-lift cage on the left side that is below the iliac crest in there safely?
I mean, I think it can be done. They actually did a good job, but it's tricky to, when the pelvis and the iliac crest are down low. It's hard to get in at L4-5.
And the neurologic injury rate is higher. So
Yeah,
final
so this was our 8-month follow-up, I believe. And so these are standing films in the office, and you can see that is quite a bit of restoration of that L5S1 lordosis, and patients doing well, and actually significant improvement in the neurodeficits. Still mild foot drop, but
yeah, he's independently walking. His hip abductors actually came back. He still has sensory deficits, and I think he just came back the other day, so he's like a year and a half out or something like that now.
yeah.
So yeah, but there's some X-rays, but he healed this. So despite having prostate cancer now, the poor guy.
Yeah.
So he had kind of a several blows against him. Any thoughts? So lordosis goal L4 to S1.
Yeah, so this is terrific. I think just getting by Gestalt without the metric up there, you can see L4 is not only horizontal, but it's a bit lordotic. Patient looks like he's got a much improved pelvic tilt. I think the alignment looks really good on this. I think Rod, your point about how do you get to the interbody at 4-5 is so interesting. We're going to have a session at NASS this year. So there's a new committee at NASS that's the anterior approach committee. It's half vascular surgeons, half spine surgeons, and working together. The L4-5 is such a controversial area. You know, Jens pointed out going direct lateral, maybe an increased risk of neurologic deficit. I'm tending to go a little more in the anti-psoas plane. In most of my cases, when I'm trying to get 4-1, I'll go direct paramedian anterior and really get a good release of the ALL. But I think you're right. This can be challenging to get that's probably a 22 millimeter wide cage there, and that can be challenging sometimes. But I tend to approach this more through an anti-psoas approach, and having that whole spectrum of options available. What's happening now is less often am I actually taking down a recurrent iliolumbar vein. So I do a lot of my own anterior approaches, and by going more in the anti-psoas approach, even paramedian, I used to always take the recurrent iliolumbar vein. I'm doing it less often now. I'm still probably doing it most of the time, but less often.
All right, fire away. Next case.
Yes, so quickly
Great
for the next
discussion.
case is a 40-year-old male, chronic severe activity-related low back pain, neuro intact, has tried every non-operative treatment you can think of. He's very active, non-smoker, low BMI. And so
If I may add to that, former boxer,
Yes.
middleweight.
So here we have our AP and flexion extension radiographs of lumbar spine demonstrating that L5S1 degenerative disc disease, slightly less so at, more so at L5S1, somewhat degenerated at L4-5, no spondylolisthesis or instability. And an MRI was performed that, again, demonstrated the same degenerative disc disease and some bilateral facet edema, but no significant arthrosis. There's a central disc protrusion, but no significant central stenosis, and mild bilateral foraminal stenosis.
I'm just going to point out something semantically, and this might be, I'm not sure if Ron and Jens and others would agree, but I think that this is symptomatic disc degeneration, and I try to avoid the term degenerative disc disease, and part of it's a Eugene Carrigy thing, but disc degeneration can be pathologic or can be physiologic. And so the term degenerative disc disease is not so much a disease as much as degeneration that's symptomatic. So I think the term that I prefer here would be there's symptomatic disc degeneration. And then why is it symptomatic? Well, is it end plate pain? Is it foraminal narrowing because of loss of disc height? But it's symptomatic. But the disc degeneration isn't the disease. It's disc degeneration that led to symptoms. Oftentimes these symptoms might be L5 radiculopathy because of foraminal stenosis. Often these symptoms might be back pain because of nociception on the end plates. But symptomatic disc degeneration.
So you brought end plates up. A quick excursion. Does, on the preponderance of cases, does the modic change predict back pain? And if so, modic 1 versus 2, we don't have a T1 image here.
Yeah, so there's a really poor correlation with the modic classification and pain. Very good correlation between histology and modic changes. So that's actually been shown in spine, and Scott Modic showed that, but the back pain doesn't. But this brings up an issue that we're working on now at UCSF. So Jeff Lotz and a woman named Sharmila Majunder. Sharmila Majunder's done a lot of advanced imaging work with MRI scans. And so we're doing some work now to look at more subtle phenotypes. So probably in the modic physiology, 1, 2, 3, edematous changes, sclerotic changes, that spectrum, that it doesn't correlate well with pain. But what does correlate, so we're looking at more subtle end plate changes. We're looking at more subtle perfusion of the end plate. We're looking at the actual chemistry of the disc using MR spectroscopy to try and get a better correlation with pain. And right now, spectroscopy characteristics, interleukin, proteoglycan, type 1 collagen, type 2 collagen, looking at the actual chemistry of the disc might correlate better with pain. But motor changes alone, I would say probably don't.
So we can spend a whole day talking about degenerative disc disorders, symptomatic disc disease, symptomatic disc degeneration. The latter term is clearly better. But in the interest of time, So this is oh yeah, good, run with it, fantastic.
Here we have a quick just spot shot of the SPECT CT with no significant facet arthropathy or uptake posteriorly, and then mild uptake in L5-S1 disc space.
That's a really good SPECT image.
Oh, sorry, I do have
and that is a SPECT image, huh?
Yep.
Because that's a really good one. We have trouble. Nuclear medicine in our hospital we call unclear medicine.
I love SPECT scans here. I mean, we have a very good nuclear medicine department. I use these for these kind of situations all the time. This is moderate disease uptake or degeneration. This is not the bright yellow.
We looked recently, Bill Dillon's one of our neuroradiologists, we looked recently at SPECT as a predictor of back pain. It wasn't a strong predictor, but SPECT is done with technetium and basically a symmetric of blood flow. And so a sclerotic end plate you would think wouldn't have much uptake on SPECT, and then perhaps something that's edematous might have more. Again, the correlation with pain hasn't been perfect. Rather than technetium, using sodium fluoride might be slightly more sensitive. Don't have great data on this yet, but the sodium fluoride is what we do with the PET scan, and that might be slightly more sensitive to actual inflammatory mediated pain.
I will look forward to that publication. I mean, I believe in physiologic testing, especially in these kind of cases, because I want to see what the facet joints look like. So assume this is a guy, he is tougher than nails, former boxer, he's dropped some weights, but his psoas is double the size of his L3-4. You can't see it on these images, but his psoas at L3-4 is massive. This guy was fit. He's a Middle Eastern refugee. He works in the IT industry now. He has 2 kids, a single father. And he says, I just am a miserable twit to my kids. So he's failed non-operative care. You can't ask for a fitter guy than that. He's had L5-S1 medial branch bundle blocks. I don't know how they'd helped a bit, but nothing specific. I mean, he's had exhaustive care for a longer period of time.
Yeah.
Assuming that he's passed all non-surgical rehabilitative efforts, and he is at the end of his wits in terms of managing. This is a former boxer, okay?
Right,
so
right. No, I get the characteristic.
So this is not a complainer. He's not on opiates, which in our region is sometimes astonishing. What surgery would you offer him?
Yeah. So first, I think what's important here is if this was just back pain, and it's not, it's leg pain as well. If this was just back pain, then the distinction I think that's important is flexion-mediated back pain versus extension-mediated back pain. And my non-operative colleagues have taught me a lot about this. And the notion of flexion-mediated back pain, could this be from end plate pathology? And might somebody with modic 1 changes, flexion-mediated pain, be appropriate for something like a basivertebral nerve ablation? I don't know the answer to that, but that would be the candidate for something like that. Having said that, this has clearly got a radicular component, so there's some neural compression. If we were to look at a T1 parasagittal image, that's the key image I look for radiculopathy, but it sounds like this person's got some L5 radicular symptoms, right, greater than left. And that's something where I'm going to be thinking about really opening up the neural foramen. So in my hands, this is going to pretty reliably be an ALIF, where I'm going to try and get at least 7 millimeters of posterior height on my ALIF. So I'm thinking about that as much as I'm thinking about lordosis. I'm thinking about at least 7 millimeters of posterior height, and then getting an indirect reduction of the neural foramen, and then either open or percutaneously in the back with regard to what the pathology is in the back.
Now, does the fact bother you that at L4-5 we have a Furman 2 kind of disc deterioration in a young guy?
It's a really important question. So where I face this perhaps most commonly, although this is a great example as well, someone with an isthmic spondy, for example, where 5-1 is obviously where the pathology is, but 4-5 isn't a perfect disc. And what are we doing at 4-5? So in my hands, in the absence of instability or symptomatic nerve compression, I'm going to leave 4-5 alone in this instance. What I've seen some of recently, and I've got no experience with, but to do something at the adjacent segment, a facet replacement, I've seen this in a couple of cases now. And again, I've got no experience. In my hands, nothing would happen at 4-5 right now. This would all be 5-1. And I would hope that restoring lordosis might actually reduce the stress on the adjacent segment. But I'd probably focus on, in the absence of L4 radicular symptoms, I'd probably focus on the 5-1.
Okay, drum roll. Question before you hit the next button. What do you think I did and from what approach?
I'm going to say that you did I'm going to say you did nail it for 5-1.
Okay, go for it. Drum roll.
ADR.
An
So
ADR.
an anterior approach, and the help of one of our experienced general surgeons performed an L5S1 lumbar disc. On the top left, you can see the distractor in place, bottom left trial, and then the right x-rays with the final implants. This is 8-week follow-up. That's where I came up with that number earlier. I apologize. This is the patient who had 8-week follow-up. You can see AP and lateral flexion extension, and he's very happy, and his radicular symptoms have virtually resolved, and he's very much active. I think he was someone that needed to be held back a little bit, actually, from returning to his normal activities.
So you are one of the absolute masters of alignment, Dr. Berven. And lumbosacral alignment is one of those really big deals. How do disc replacements fare in terms of restoring lumbosacral alignment, that vulnerable L4 to S1 alignment?
Well, first of all, I like the approach, and one of the last times I was up here was for your disc replacement symposium. So I think the attendees of that symposium, including the TBI folks and some of the folks from Cedars, would have been very disappointed that I didn't even bring up the disc replacement as an option, perhaps sparing the 4 or 5 level. Having said that, I think that theoretically, a disc replacement's terrific at 5-1 because we're not dialing in that lordosis, as we're allowing the patient to create the lordosis. Having said this, when we look at the flexion image, I'm not seeing a lot of mobility there.
3 degrees to 5 degrees is what I documented. I said 3 to 5 degrees.
Okay, from flexion to extension?
With a slightly mild, biased opinion.
And
I tried not to.
And we also recognize that if this actually fuses with heterotopic ossification, the 10-year follow-up will be perhaps even better if it fuses. So, there's a disc replacement in there, but there's not a terrific amount of motion there. I think theoretically, this could be a terrific option because it allows the patient to dial in their lordosis, but I'm not necessarily seeing this as being a motion-preserving operation right now.
Now, I do have to say, in defense of disc arthroplasty, so number one, the Thierry Marnet article in JBJS earlier from this year, I think, January, February,
20-year follow-up?
20-year follow-up.
Right.
That is pretty remarkable. Now, the guy's an artist. He's a frequent visitor here. But that number, assuming that this was really done in an unbiased follow-up, and I think that was the case, but just making that assumption, that is a pretty remarkable series of like 1,200 patients. The second thing I'm going to throw out there is Rick Geyer and Scott Blumenthal. And by the way, shout out to them last night. They had in our quarterly disc arthroplasty forum, they presented the first U.S. patient with a Charité disc. She made a public appearance. They showed her images. She discussed her course. Pretty moving. That was a really cool patient testimonial. 25 years ago, 2000, she had a Charité put in. She looks fantastic. That Charité disc, much maligned, still moves.
Yeah,
that's pretty cool.
Karen Butner-Jans was actually in Tampa, which is where you're going to, right, Nick?
Cameron.
Going to. So Karen Butner-Jans was just there for the Neurosurgery Spine Summit. So you're looking at, 25 plus year follow-up on the Charités.
But they pointed out a under 1% revision rate of disc replacements. Yeah. For hip replacements and for knee replacements, the 10-year survival is about 90%. And that's these hip replacements are the surgery, often touted as the surgery of the century. 1%, 25 years later, in U.S. hands, that's not bad.
Yeah, I think in the hands of good surgeons, Geyer, Blumenthal, Ziegler, those guys do a terrific job technically. The revision rate can be quite low. Same level revisions.
I think as Cameron comes up, the only final thing I would say is I think our flexion films are not true flexion films. I think that he's very much hinged at the hips, and we've taken another neutral film, just as you can see. But that would be my also adding to that.
Great point. This was, and again, he's 8 weeks out. He actually was just back, and he loves it. I mean, this is one of those things. He literally walked out, and the radicular component is a big deal. Talking to a late convert, Dr. Oskulian, you were a skeptic for a long time, and I've seen you booking these more and more now.
No, you know what? Honestly, I have to credit Jens. He kind of, I would say back in 2014, it's one of those procedures where you have to pick the right patient. Patient selection is so important. And then technique, you know, I learned a lot from Jens doing these operations. You really have to go in, and those intra-op radiographs show it. He goes in, he takes the PLL out, he goes really lateral, and then he uses that distractor to really open it up. I have to say, honestly, I think I didn't do a good job early on in my career with these, because you kind of just want to get the implant in, but you have to spend that extra time to get the foramen open.
Yeah, that's something I learned really early on. I was taking down the PLL, and I actually do that now in most of my fusions. If I'm trying to really get foraminal height, then I'm taking down the PLL just about every time. And some of the techniques, the David spreader that the original Charité had, those are tools I still have in my operating room to actually be able to tear the PLL and small curettes, get back there and take it off the top of S1. Those are tools I really
and it makes a big difference. And honestly, the patients do so well. The sad thing is, I do think between industry, insurance, and a bunch of other things that there was a kind of a decline, whether it was reimbursement or whatever it was. And it just, for like most surgeons like myself, it was a really important tool and thing you can have in the back of your pocket for like a patient like that. So
yeah, no, but great points. And again, speaking about cervical and lumbar disc arthroplasty, my experience with those since 2000, I hope, has made me a better anterior fusion surgeon, because that release is so critical. And I think your cages will also, cage talk will still emphasize that there's still surgery to be done.
Yeah, for sure.
Talking about Tampa, has a decision been made, Dr. Hogshead?
It's close. Well, yeah.
Okay, let's try
close to official.
Let's try to go through this a little bit faster, because we have two more cases and we want to be on time for our visiting professor's presentation.
Sure. Speaking of spondies, 40-year-old female with worsening low back pain, and you can see her x-rays that she came in with clinic visit. This is a standing neutral x-ray lateral. She had progressively worsening pain in the last 5 years. It's become now debilitating. She also reports pain that radiates down her right buttock and thigh, and she also has some bilateral lower extremity weakness of the feet, self-reported, that's right greater than left. She has tried all of the conservative managements, including PT, PO meds, multiple epidural steroid injections that gave her temporary relief lasting up to a month or more, but return of her pain with a vengeance. She has no remarkable past surgical history, medical history, social history. So on her motor exam, you can appreciate that she does have some L5, S1 motor and sensory deficits. No bowel or bladder symptoms there. On exam, she's also unable to heel walk and was unable to squat, secondary to significant low back pain. So here are flexion extension x-rays. You can see an unstable grade 3 isthmic spondy at L5, S1. Those are her lumbar parameters there. So not really a PIL mismatch, but you can see significant slip angle there and near spondyloptosis.
It's interesting. You say that this is an isthmic spondy, which in a Wiltse classification, I certainly agree. This has really got a lot of characteristics of a dysplastic olithesis. So we think about essentially an acquired olithesis versus an dysplastic. I think the dome in the sacrum, the trapezoidal changes to L5. This is and the higher grade. This is something that probably reflects underlying really high pelvic incidence, which I'm surprised pelvic incidence is 54. But sometimes this could be associated with the higher pelvic incidence. But this definitely got some dysplastic features, which I think makes it different and in some ways more difficult to manage. Then when you say that there's not really a lumbar pelvic mismatch, well, the reason for that is if you look at how much lordosis there is at 3, 4, and 4, 5, right? So this is somebody who's young enough to still be compensating through this. So if we think about the Labelle classification of spondylolisthesis and someone with global alignment, lumbar pelvic malalignment, that sacrum's pretty vertical. So I say this is probably like a Labelle 5, meaning that they've got a lumbar pelvic malalignment, globally compensated because they're hyperlordosing. But if you were to fuse this in situ, the 4-5 would wear out incredibly quickly. Right, so this is one where I think this is an alignment problem, but it's an alignment problem at 5-1, and it's a compensated alignment problem. But these are ones where we actually did a study in adults with spondylolisthesis, where if we leave this with a lumbar pelvic malalignment, the outcomes are clearly worse.
Yeah.
So lumbar, so many valuable things: trapezoidal L5, sacral dome, cupping, dysplastic. You're very prescient, and we documented as such also on the CT. You have that, right?
Yeah.
And then the wedging of the discs. So whilst you scroll through it, I'm going to go to our Tacoma colleagues, Drs. Covey and Martin, and ask them to weigh in on anterior versus posterior or combined, and reduction or not. Dr. Covey, thanks for joining us.
Thank you. I would attempt this posteriorly, and I think you don't necessarily need to get a full reduction, but you'd need a CT scan to look at the pedicles of L5, because sometimes they're so dysplastic that in the process of trying to pull back, you're just asking a little bit too much. And this would probably be good for bilateral expandable cages.
So all posterior. What about your colleague in the pristine, freshly pressed white shirt, Dr. Martin?
Thank you.
Your complexion looks way too healthy for this area.
It's been sunny. I had approached these anteriorly in the past and had, due in part to the approach surgeon, but had some significant vascular complications with these high-grade slips and trying to get them reduced. So I too would approach this posteriorly. If I was able to get some distraction and get some reduction with positioning, I would consider putting cages in. If not, I've had good results. Haven't done it recently, but using a fibular dowel just across the disc space from behind. But you have to include 4 or 5 in there to try to restore some lordosis.
So retrograde transsacral in situ Bowman graft.
Yes.
Yeah. Okay. Great, Dr. Berven. So I see a lot of, and this is actually a voice of reasons here. I'm very happy to see that. I've seen a lot of anterior fusions now for isthmic spondyes, even higher grades, and then attempts at posterior percutaneous screws, ending at S1 and ending up in revision situations. This is kind of the norm now. What are your thoughts on how this should be ideally treated, alignment-wise, L5 root safety-wise, etc.?
So yeah, this is a challenging case. It is a dysplastic spondee. I'll give the preface that Josh Covey was a senior resident at Harvard when I was there, so I think that there's some congruity in our thinking, although probably we didn't do much of this in residency. This is post-residency. Having said that, I really like the anterior approach. But this is one where I agree with you. When you're talking about doing this with an ALIF and posterior perc fixation, this is one where I'm certainly going to get some fixation into pelvis. There's a lot of strain on those S1 screws as well as the L5 screws, so I'm going to get some fixation to the pelvis on this. As much as I like anterior spine surgery with that dysplastic sacrum, and getting that to the front isn't that tough, but you're taking off the anterior osteophyta there, trapezoidal L5, and I've got plenty of surgery, plenty of cases where I've done this. This is where a custom cage can be very useful to accommodate that dome sacrum. But in my hands, most of the time, I'm going to do this posteriorly, 5-to-1 pelvic fixation, and specifically in avoiding L5 nerve root injury. This is very specific. Is I'm trying to restore lumbar sacral lordosis more than the slip angle, or more than the slip grade. So I'm trying to improve the slip angle more than the grade. What I mean by this is that I might leave this as a grade 1 olithesis, but I'm going to try and get lordosis between L5 and S1. And the way to do that safely, because that sacrum's domed, essentially you're pulling L5 up unless you take the dome off the sacrum. So this is a lot of interbody work in my hands. I'm using the osteotome, taking the dome off the sacrum, actually shortening the sacrum, and then reducing it after I've shortened the sacrum. And I agree with two interbodies here. I think it can be really useful. And then pelvic fixation, I think, is a critical part of it.
So she's 40. She's had 6 kids. She actually looks great. And when I asked her, are you planning on having more kids? She said yes. So would you, in a woman of childbearing age who is not done with procreation and has had natural child delivery throughout, give her a pelvic fixation?
Yeah, really important question. So, what's the role of the SI joint during delivery, during pregnancy? Really, really important question. I think about this a lot also in kids, right? Is pelvic fixation in kids. So I could tell you in kids and perhaps in a woman who's planning on having more children, but in the adolescent population as well, what I've done is used iliac fixation. So rather than going through the SI joint and doing S2AI screws, I've used iliac fixation and then subsequently taken it out. But I think reducing strain on the S1 screws is important. And in my hands, I probably would still add some pelvic fixation here.
All right, drum roll, take us forward.
Yes. So you can see our intraoperative x-rays there as similarly discussed. It was an all posterior approach with bilateral releases of both L5 nerve roots widely decompressed and visualized before reduction. And you see dome of S1 and L5 osteotomed release there as well. And then S2 alar screws to help take some stress off of the S1 screws.
That's a nice compromise.
Yeah.
To avoid crossing the SI joint. You know the biomechanics of this isn't great. So how much does it take to strain off of the S1 screws? Not crossing the SI joint just maybe takes the strain off. Again, Cunningham studied this specifically, maybe about 30% compared to taking it down about 200%. But it's a nice way to avoid the problem of the SI joint.
We engage the anterior cortex, and it's exactly that number. We actually tested in our Harvey lab, but I don't think we actually published that in the end. This is an anti-toggle screw for S1. That's the only function. It has no pull-out strength.
Yeah.
Then you can see previous lumbar lordosis, pelvic incidence obviously didn't change there from previous. Why? Because as we talked about, there is a compensatory relaxation of that upper reactive hyperlordosis of those segments when the slip angle was reduced and L5S1 had, or L4S1 was lordosis was increased.
Yeah, that's a really great example. If you look at the L4-5 alignment, it was really lordotic preoperatively, a lot of strain on that segment, risk of adjacent segment problems, and now that relaxing kyphosis or relaxing restoration of alignment puts a lot less strain on that segment.
So I'm not sure where her L4S1 will end up. We were supposed to get a lateral x-ray before she left, and she left before she got the lateral, which I was not happy about, but so it is. But what L5 root deficit do you quote patients when you do a reduction of an higher grade isthmic spondy?
So we did a study on specifically that in the high grade spondies. And what we showed was we considered, we looked at how well does intraoperative nerve monitoring predict a posterior deficit. And in our case, because you're shaking your head a little bit, but in our case, it actually, patients with intraoperative changes ended up more often with pain than weakness. The weakness, if I recall from the paper, there was transient weakness in about 15%. I think it was more than 10% of people, transient weakness. By 6 months, there was only one person who had measurable weakness to L5, but transient associated with multiple myotomes. So MEP testing to multiple myotomes in patients with higher grade olithesis. If I recall, it was about 15% of patients had some weakness, about 20 to 30% of patients had some pain. And interestingly, the MEPs in multiple myotomes was actually pretty sensitive to detecting that.
So go back to the pre-op CT. So she had no deficits afterwards. We're very happy with it. Our poor fellows who worked with me were sweating through my compulsion. I personally have a theory as to why these L5 palsies happen. And this patient didn't have it severely, but can you stop on a sagittal in the foramen where on the one side she had a pretty big lip? That inferior L5 lip, the back of L5 lip, spur. The traction spur at L5, the one side had it worse than the other. This is not a particularly pronounced one, but I nowadays really make a point of osteotomizing it off with a small feathered osteotome to take that off. Because in our AO prospective study with Paul Arnold as lead author, we had the same incidence of radiculopathies in anterior and posterior surgeries. And I looked at some of the images, I was one of the evaluators, and this persistent lip was the problem.
Yeah, and that's and this is also if you don't shorten the sacrum with the sacral dome osteotomy, then you're distracting that, and it's the lip that forces that L5 root to be higher.
It gets tented.
And
it's
that's
very hard to take out. We actually took out the S1 dome here.
That's a lot, and you see how you took off the back of L5. It's a lot easier to do with the T-lift than it is You know, you really can't get that effect.
I'm not sure. I'm super happy. I'll be curious to see your cages with my L5S1 lordosis. I would have liked to have maybe a little bit more, but I'm just going to say right now I was happy with it, and I was thrilled that she did not have a L5 palsy or a sensory deficits.
Yeah, I think what we showed is getting people out of kyphosis. So she's about 20 degrees kyphotic. So I think you got at least 20 degrees of change. And you know, it might not be terribly lordotic, but it's to neutral at least.
I appreciate your power of positive lens. Thank you. Dr. Castillo, and with potential apologies to Dr. Kramer, I want to try to get through two cases. Dr. Castillo is from Santiago de Chile. He's here for a month. We thank him very much for dedicating his time to being with us. It's been awesome to have him here. And he was in clinic with me, and he saw a longer-term follow-up on a scoliosis patient.
So good morning, my name is Cristóbal Arca Castillo. I'm an orthopedic surgery resident from Chile. Chile is a long country at the bottom of South America. In the middle of Santiago, of Chile is Santiago, my city, city where I come from. And I'm currently doing my residency in two hospitals. The first one is Clínica Alemana, a private hospital. I think the best one in Chile probably. And the other one is Hospital Padre Hurtado, a small public hospital in the south of Santiago. So the clinical case is a 58-year-old woman with a 3-year history of low back pain radiating to the left buttock and intermittent right leg symptoms. So past medical history, he has rheumatoid arthritis in treatment with sulfasalazine, and she's anxiety, and she had arterial hypertension. Her body mass index was 20, and her DEXA scan was minus 1.2 of T-score of the femoral neck. She had not previous spine surgery, but she had 2 epidural steroid injections without relief of pain. And she's wide awake. She was a former smoker, and she's retired. So there are not motor or sensory deficit on physical examination. So these are the X-ray and anteroposterior and lateral X-ray that show degenerative scoliosis with a 17-degree left thoracic curve and also a 44-degree right lumbosacral curve, and moderate degenerative joint disease of the lumbar spine. So this is the MRI that show severe degenerative scoliosis with disc protrusion in level L2, L3, and also L4, L5. That cause foraminal stenosis on the left side and L2, L3, and on the right side at level L4, L5. This is the CT myelogram that confirmed the findings on the MRI. So, in summary, we have a 58-year-old woman with severe degenerative scoliosis with foraminal stenosis at level L2, L3 and L4, L5, and also lumbar spinal stenosis.
So great summary, Cristobal. So this is something, I'm not bragging here, 30 patients today. I will probably have 10 patients with this presentation. Sig, you wrote one of the classic landmark papers through the SRS that shows that this is a growing epidemic. What's going on? Is this true? Is this just an expanded diagnosis appreciation?
Yeah, really important question. Actually, Cristobal and I were talking earlier. One of his mentors there in Chile, Dr. Julio Uratoa, and I wrote a paper largely based on Chilean patients looking at DEXA scans and the prevalence of scoliosis in adults. I think the first question is this an idiopathic scoliosis or is this a degenerative scoliosis? And sometimes it can be tough to tell. I think this has got more features of a degenerative scoliosis, but the fact is, as you pointed out, there's a bit of a structural thoracic curve, and it would be interesting to see what this looked like during adolescence. She's 58 years old. I suspect that this is degenerative changes superimposed on an idiopathic problem that started. Now, when I think about what to do with this, in broad categories, I think, first of all, operative versus non-operative. Sounds like she's progressively symptomatic and needs surgery. And then second of all, how high to go, how low to go, and then when to go front and back. So what you're showing us here is primarily, my understanding is back and radicular pain both, right?
Yeah.
I saw there's some weakness to the hip flexors on the left side, I think it was, and that was so it sounds like the symptomatic stenosis at 2-3, maybe 3-4 is not insignificant. My question is, can I spare 4-1, or can I spare 5-1? Looking at the MRI scan, 4-5 and 5-1 doesn't look bad, but I think if I saw the CT scan, there's a lot of foraminal stenosis at 4-5. So the first thing I was, or maybe not, was 4-5. So my first question is, can I go short of the sacrum? Now, so often in adults, we just sort of default to going to the sacrum. In this instance, I'm thinking, can I possibly stop at L4, somebody with reasonable bone quality, right? Texas score was -1.2, somebody with primarily radicular pain. Is I'd be tempted to try and do this 1 to 4, and leaving 4-1. And 1 to 4 in my hands is going to involve an anterior, actually it ends up being a thoracolumbar approach, an anterior approach from 4-1 and a posterior. I can't do this like a type 5 curve. I can't do this all anterior. But this is one where I would think about, first of all, evaluating how much of the pain is coming from the lumbosacral junction. Okay. Somebody's got a lot of pain from the lumbosacral junction. It's easy to default to going to S1 or going down to the pelvis. But this is one where I might think about, especially if, again, there's not much pathology from 4-1, maybe going 1 to 4 on this.
So before we unravel what we did, go back to that AP, Cristobal. This is nice assembled. What scares me most about this image is one thing: pelvic obliquity. I see a higher left iliac crest than right. That bothers me, because if I straighten out the spine, I might have a patient who's off keel. What do we do to assess this pelvic obliquity aside of a good physical exam with hip range of motion, et cetera? It's like, do we put leg length bars on? Is this all clinical? Is this gestalt? How can we account for this?
Yeah, so I think the EOS is useful here to look, and on a physical exam, taking a look at a true leg length versus a apparent leg length discrepancy. So specifically, ASIS to medial malleolus is your true leg length, and then looking at umbilicus to medial malleolus is your apparent leg length. If the true leg lengths are equal and the apparent leg lengths are off, then this obliquity is secondary to the deformity. If the true leg lengths are actually off, then you got to think about using a Coleman block and saying, hey, do you want to wear a lift postoperatively, in which case I make you parallel to your pelvis, or do you not want to make a lift postoperatively, in which case I retain that obliquity? So a lot of thought goes into the patients who have an obliquity preoperatively, and I think that's a really important question. Is, if the true leg lengths are equal here, then I think the obliquity is secondary to the deformity.
All right, let's take us to the resolution, because I would really love to see the last case. I also don't want to shortcut you.
So
all right.
They did a decompression with an interbody cage from L1 to S1 with a posterior fixation from T10 to pelvic.
And how did she do? How's she doing?
Oh, I'm sorry.
This is all done posteriorly?
No, X lifts. We have the X lift master sitting right behind you, and we'll talk about that in a second. She's 8 years out now?
Yeah. Actually, she have a 9 years follow-up. These are the X-ray, and she has been feeling really well with a good range of motion. She has no pain, and she's living an independent life.
Yeah, so this is one of those complete scores. I mean, she literally has 0 adverse scores. She just checks in ever so often because she is, quote, paranoid, and I told her adjacent segment disease, which she is featuring in her thoracic disc there, will happen. Dr. Oskuin, you were so kind to lend your XLIF expertise for years in these cases. Talk to us about left versus right, and we're not doing that much anymore. What are your thoughts on XLIFs for adult deformity correction?
I mean, I think this is a good example of a case where I think we utilized it, and I think it was very effective. I typically go from the left.
So it doesn't matter concavity versus convexity?
Yeah, it doesn't matter. Yeah.
And in 5-1, was it T-lift then?
I think it was a T-lift, yeah.
I think I did 2-level T-lifts, 4-5, 5-1. Dr. Skuin is fantastic, because when he says there's too much electric noise and too much proximity, he doesn't do it. So we always had the XLIF roulette. Will it be 1, 2, 3, or 4 levels? And that we call that XLIF roulette. And I took bets before, but he never injured a neural plexus there. So my point is, these were very unsophisticated in a lot of ways cages. We did not have anything fancy here. I would nowadays do quad rods. But she did fantastic. And again, she's a former smoker. She formed bone like crazy. We did not even use bone morphogenic protein on her, as I remember. But I want to also point out the pelvic obliquity. I talked to her beforehand about it, and I got away lucky. But I am still scared about when I see pelvic obliquity on x-rays.
Yeah, and I think determining is it a true leg length discrepancy versus not. Here there's still a little bit of obliquity, but she looks like she's overall well aligned. I'm interested in 1-2. Your experience at L1-2. She did 1-2, 2-3, 3-4 direct lateral, and then you did T-lifts at 4-5 and 5-1. When do you think you need to get an interbody at 1-2?
I mean, usually, unless I think you're right. It's pretty rare to go to 1-2.
Yeah.
But I think it just depends on the case. I think you pointed out earlier she had a bad thoracolumbar. So
yeah, and what's interesting here is when I'm doing direct laterals and people with this much rotational subluxation between vertebrae, is at every level I'm actually moving the OR to be able to get it completely perpendicular to the floor, because there's a lot of rotational subluxation, and sometimes, especially at 3-4. A lot of rotational subluxation can be difficult to get an interbody.
Yeah. Well, and I think when you go anterior, you lengthen the spine. Whereas, if you're going posterior, regardless of what expandable you're doing, I think it's a lot more difficult to get a good three-dimensional correction.
Yeah. Hey guys, so we have the following logistics issue. So we want to hear your guest lecture, and that's supposed to start now. We have 2 cases. Shall we start with the lecture now, or how do you want to proceed?
You got the audience here. You let me know actually just the length of the lecture versus you let me know.
So we'll do Mark quickly because that is pertinent to your talk, and then if we have time afterwards, we'll go for Colin Gold. And I apologize if Colin Gold gets delayed again. I did that to him before, but we want to do this very quickly. The main point, the initial surgery, we can talk endlessly about this, but let's get to the main point. That's
great. I'll jump through the presentation real quick. 75-year-old woman, no previous spine surgery, back, leg pain, bilateral leg pain, L4, L5 distribution, also some left groin pain, had a L4-5 ESI, good improvement for about a week, no significant past medical history. And as I note here, she ended up having a hip arthroplasty, a bunch of orthopedic surgeons in the room, probably looking at her hip x-rays here. She's got normal exam. Here's her flexion extension films. And I gleaned these numbers myself. I don't have any scoli films to show, but you can see she's got a very high pelvic incidence. Lumbar lordosis is actually quite good at 60 degrees, but there's still a pretty significant mismatch. I mentioned a sacral slope, and I have 2 different measurements there, and I'll show you why in a sec. So here's the MRI showing this is probably more like a dysplastic spondylolisthesis at 5-1 as well. And at least from this, you can already glean that she's fused there. And then she's got severe collapse of the disc and foraminal stenosis and central stenosis at L4-5, and to less extent at L3-4. And then that big, the top image on the right shows that big bony ridge at S1 is compressing the distal nerve roots there as well. So here's the CT myelogram. As you can see, vacuum disc at 4-5, fusion at that dysplastic spondylolisthesis 5S1, and then kind of end stage disc collapse, if you will, at 4-5 and 3-4. So in summary, 75-year-old woman, claudication symptoms, radicular symptoms, fusion 5S1, severe stenosis at 4-5, foraminal and central, foraminal stenosis as well at 3-4.
So just to, so many important points here. I agree, it's a dysplastic scoliosis. This truly is fused at 5-1. There's so often when it's not, but I'm convinced that this is fused at 5-1, probably spontaneously, no prior surgery, right?
Exactly.
So this is one, and I think you're already alluding to this, real high pelvic tilt, real retroversion of the pelvis here. And I'm not a 75-year-old, and I've got several cases of S1 PSOs. I'm not going to do an S1 PSO on her. If you're younger, maybe I'd consider some deformity correction there. But this is one where I'm going to accept that her pelvis is essentially L5. So her L5 incidence is what I'm looking for. So I'm no longer trying to match the pelvic incidence to the top of the sacrum. I'm matching it to the top of L5. I'm accepting that this is a sacral unit, and then trying to build off of there. In my hands, I often say the presence of a vacuum disc is an invitation to do an anterior approach. And Jens, you're as good as anybody I've seen at posterior interbodies or intradiscal osteotomies. There's no question this is going to be an anterior approach in my hands. I'm going to go from 3 to 5, and then get as much lordosis as I can. Then in the back, this is a subtle thing and probably not that important. I'm actually going to decompress to see what I can do to. She's got some S1 radiculopathy. Might even take off some of that bony ridge from the back with the osteotome. But here's the critical thing, maybe not critical, but she's 75 years old. I'm dealing with a high stress construct now. I've got an anterior from 3 to 5, and I'm putting my S1 screws up into L5. Not necessarily with the fibula in this case because it's already fused, but I'm getting 75, 80 millimeter screws from S1 up into L5 and pelvic fixation.
Like a Bowman.
And I want to acknowledge the left hip arthritis. We recognize that. We talked to the patient about she had cysts and in her femoral head. So take us forward, and warning, there's a complication. So, and by the way, those S1 L5 screws, who described those first? Is that Chris Shaffrey? I give him credit.
I would have attributed that to Bowman. That's kind of part of
Bowman.
it.
Okay.
Bowman technique.
The Bowman
But
graft,
yeah, I'm
yeah.
sure. Yeah, Shaffrey definitely. This is something that we've done for a long time.
So we
for
had
sure.
the hip replacement done first, then we did this. And
Exactly.
what did I'll tell you, something failed. Tell me what will fail, and what do you think of these images right now?
But her Hounsfield units, right, were 60.
134.
Oh, was it 130? Okay.
134. That was really nice to put that in, Mark.
Yeah, so that implies that there's some decent bone here. This is impressive that you really got this kind of reduction from the back. So 3-4, 4-5, and with in this case no fixation directly into 5, but rather the transosseous screws.
On the direct vision, so that one screw on the left side is not in the neuroforamen, or in the canal. This is on the direct vision. They look odd, but yeah.
Yeah.
So what will fail?
So what's going to fail here? So there's a lot of stress between the L4 and the S1 screws, right? And so there's a big gap there. I would say the most common, looks like you got a cobalt chrome rod in there, or at least it's at least a 6.0 titanium rod. And the most common failure in this would probably be a rod fracture between the 4 and the 1 screws would be most common. There could be some subsidence of the interbodies, but I would say, if anything, what I think it would be at risk is a fracture of the rod.
All right, take us forward.
Of course. So
Drum roll.
she's doing quite well for about a year and a half. Recurrent intractable low back pain. I present her ODIs here as well. You can see preoperatively 47.53, and then 5 months post-op goes down to a 9. She's doing very well. And 11 months, kind of back up. 18 months, back up to almost a 50. No falls, no trauma. These are the X-rays that are obtained at that follow-up time.
It's interesting when you routinely measure your outcomes. One of my partners, Shane Birch, I think does a really good job of this, of sort of graphically having outcomes in this pattern. So recognizing a pattern of better to suddenly worsening. There was actually a paper out of Mass General that Kirk Wood wrote about using this for whether or not to get a postoperative film at all. Yeah. And this is something where I'd say, okay, between that 5 months and subsequent follow-up, I'd be thinking about certainly getting a postoperative film.
So this is beautifully juxtaposed here, Mark. Okay, take us forward.
So now she's having weakness right side. Pain is more so on the right side as well. Some sensory changes. Here's the MRI.
Wow.
L2-3. So no obvious rod fracture, no hardware complications, obviously, but she's got some obvious PJF or PJK.
So I tried not to do too much, and I thought I did okay with the alignment. I didn't hear a direct complaint by you, and this next level just blew apart. So adjacent segment failure of epic degrees, just down out. Could I have done something to prevent this? Could I have immediately should have just gone higher or prevented her from gardening, which is her passion in life?
Yeah, I think if you can't get somebody back to gardening, then it's not a successful surgery. If somebody's got an ODI of 9, they're going to get back to gardening. Could you have gotten more lordosis with an A-lift versus T-lifts? I don't know. It's hard to criticize. If you look from 3 to 5, right? The reason this failed is because there was a lot of strain on the 2-3 disc, right? The reason this failed is that 2-3 was making up for a global malalignment. But having said that, this might be something. This would be tough to do better without an S1 PSO, which in a 75-year-old isn't going to be the right answer either.
So we have to operate. There's a large rostrally extruded disc herniation. There's a lateral subluxation, my personal biggest nemesis in spine surgery, lateral subluxations, scoliosis. How do we fix this now, and how high do we go? Do we monosegmental? Do we just do a decompression? Do we go much higher?
So this is 2-3. 1-2 doesn't look great at all. It's a big extruded disc fragment. I'm not just going to do a discectomy here because that 2-3 has obviously failed. So this is an interesting one for when do we need to cross the thoracolumbar junction, right? I think we do too much fusion of asymptomatic discs. And this is one where I'd probably do 1-2 and 2-3. I'd probably, in my hands, this would be a lateral at 2-3, followed by an open posterior decompression. But with lateral 2-3, I'm going to try and get as much lordosis as I can. I do that better than I do a third level T-lift. I think my fusion rates are better. I'm going to take this probably up to L1. But I'm not going to cross the thoracolumbar junction. The only caveat is I look at the pedicles of L1. Sometimes those L1 pedicles are very small. I want to get at least a 6.5, if not a 7.5 screw in there. So the only reason I might take this up to 11 would be if the L1 pedicles are too small.
Okay, Dr. Kramer, Dermal, take us forward. We crossed. We didn't listen to you.
Cross in the thoracolumbar junction. In this case, all from the back, we actually did just a single level TLIF, or in this case, IDO at 2-3. It's a very aggressive IDO. You can see we really pulled her back at that level. And now she actually just showed up to clinic recently doing very well. She still has a little numbness in her legs, but she's actually very functional. She's living independently, very happy.
One of those people, despite this fusion, who predictably puts her palms on the ground with knees straight. It's pretty remarkable. Yeah. So far so good, but again, we're obviously going to carefully monitor her thoracic spine now, but so far so good. She's very happy.
A lot of correction at 2-3. That's an impressive intradiscal osteotomy there. In some ways, with that extruded disc, is sort of nice to do the intradiscal osteotomy. That's an impressive correction at 2-3.
Yeah.
And I probably would have done that front.
Question. So first of all, I want to thank Dr. Kramer, and he's going to join us. He's signed his contract, so we're super excited to have a great colleague like him, a neurosurgeon from Wisconsin originally. So it's fantastic to have you here. Thank you for that. Are we allowed to give you one more case?
I think Colin had to go down.
Colin had to go down?
Yeah.
Okay, then we are ready for Dr. Berven. Thank you to our presenters. So
Good
apologies
job, guys.
to
Those are really good cases. Yeah.
Thank you. Fun to discuss things with you always. I love this format and so much appreciate you being here. So Professor Dr. Berven does not require an introduction. This is too long to read. We want to thank Carlsmith for bringing him here, but Dr. Berven is professor and spine surgeon at UC San Francisco, a global name in spine surgery, deformities. He is, and this should be pointed out, a graduate of human biology and economics at Stanford. He also studied philosophy, politics, and economics at Oxford, a minor little thing, and then medicine at Harvard School. He's true royal blue blood. He's chief resident at Boston Children's and his spine fellowship at UC SSF, where he's been stuck since then, and he's influenced the world for us. He's in all the major organizations, SRS, AAOS, wherever there's a major spine organization, he has left a significant footprint there to the betterment for all of us as grateful surgeons and patients. Thanks for being here and talking to us about the next generation cages.
Well, thanks, Jez. Thanks, Rod, and the whole SSF group. Thank you, Carly. Thank you for being opportunity to be here. Every time I come, in part preparing for these talks, in part being here, I really learn a lot. So we're trying to end this promptly at 8. Is that right? So last night, as I was kind of adjusting things, we'll readjust now. What I'm going to talk about, and this is going to really be a non-CME portion, is I'm going to focus on specifically my experience with these personalized interbody cages. So the Aprevo cages by Carlsmed, I suggested I do quite a bit of work with anterior surgery. There's a lot of different companies I use for anterior surgery, and the Carlsmed, I've been a consultant with them, as well as other companies that make anterior cages. But I'm going to talk specifically about where the personalized Carlsmed cage has been part of my practice. And the fundamental goal here is to try and reduce implant-related complications. So number one reason for revisions in deformity surgery, and that's why I suggested that the rod fracture is going to be a failure rather than the adjacent segment. But the number one reason is implant-related complications, junctional pathology, as well as rod failures, trying to reduce revisions, improve outcomes through interbody cages. And fundamentally what this cage is doing is improving end plate contact area, so less subsidence, improving the reliability of achieving our alignment goals. So this whole morning was about achieving those alignment goals and doing that reliably. Reducing stress on the posterior rods. So really good evidence that 30% with a good congruent end plate, we can reduce stress on the posterior rods, reducing those failures. And then, as the last case suggested, by getting good alignment, reducing adjacent level pathology. So that's the fundamental notion here. Alignment really, this has been something that's really has been a big part of my 30 years in spine surgery, nearly 30 years now. It started off with a paper that Steve Glassman and I and some others wrote, looking at alignment and specifically focusing on C7, SVA, looking at coronal and sagittal, and suggesting which parameters matters. Well, we said the ones that have an impact. And C7 SVA is what we started with as being the biggest impact. Then with Frank Schwab and Virginie Lafage, bringing into this the notion of some of the pelvic parameters, trying to improve our pelvic tilt, trying to match our lumbar lordosis to a pelvic tilt. And now the alignment parameter that I'm using most often is actually the gap score. So looking at the distribution of lordosis. And so often I think where we have failures is when we fail to restore lordosis at the bottom. So specifically from L4 to S1, getting that lumbar distribution index lined up. And what's interesting is regardless of the Rousselet type, regardless of whether or not we've got a relatively horizontal sacrum or relatively high pelvic incidence, high sacral slope, we want to get about 35 degrees from L4 to S1. So this ends up being pretty much a constant across populations. When we think about restoring the functional spinal unit, then number one, we want to be decompressing our neural elements. We want to try and redistribute lordosis and realign the spine, and trying to avoid mechanical complications of adjacent segment pathology, as well as maintaining alignment, getting a solid fusion, avoiding subsidence of our interbody cages. And it was interesting to me to see how many of those cases had two interbodies on the T-lift. So really trying to optimize that footprint, right? And both Josh, but a lot of these cases had two interbodies. How good are we at restoring alignment? And this is an ISSG paper that Justin Smith was the lead author on. It was interesting is looking at patients with complex adult deformity, matching lordosis to the goal only happened about half the time. So we're not very good at this. And I would suggest to you a big part of this is if we looked at the posterior-only surgeries with posterior interbodies versus front and back, that the posterior interbodies and posterior-only based surgeries did worse. Well, that's for deformity. What about degenerative pathology? And J.C. Levesque and I think Ross Shethy was part of this. We talked about the degenerative pathology and recognizing that even in degenerative pathology, the reliability of improving lordosis isn't good. So just as likely to create kyphosis as lordosis. And this is my criticism of a lot of minimally invasive techniques, is the loss of lordosis, especially at L5-S1. And I think that the critical nature, so our interspinous devices, our T-lifts, especially from 4 to 1, transsacral devices, all of these were attempts to address the lumbar sacral junction in MIS way. And I think all of these are a real problem. And the reason for failure is essentially that loss of lordosis or the inability to restore lordosis from 4 to 1. So this is where patient-specific interbody devices have been a big part of my practice. And you can see here, this is what I'll actually get is based on a preoperative CT scan, is I'll see whether I'm going to do T-lifts or A-lifts, is I'll see what's the expected correction with my anterior interbody alone. And for each patient, having an implant designed so it has perfect end plate congruity. So how well do we do with these patient-specific interbody devices compared to stock implants? Well, what's interesting about the stock implants is whether we've got a 10-degree cage, a 12-degree cage, an 18-degree cage, there's very little correlation between the lordosis of the cage and the lordosis of the segment. A big part of this is, I think, percutaneous fixation. Right, a big part of this is the absence of actually mobilizing the spine from a posterior approach. So the cage alone doesn't necessarily work well. And a big part of this is just a lack of congruity between the cage and the end plate. And this leads to, again, unpredictable realignment, as well as, in a lot of cases, subsidence of the cages. So this is a study that was sponsored by Aprevo, and Jay Asher and Rodrigo Nicolau were the leads on this, but 135 patients who actually had personalized interbody implants. So comparing it to that historical data, then the reliability of getting our preoperative goals, reliability of reducing postoperative malalignment, especially 4-to-1, was dramatically better. So much better realignment with these patient-specific cages. Comparing this to, again, our preoperative goals, how often are we getting within 5 degrees? Well, with the A-lifts, more than 90% of the time, compared to, I showed you 50% in deformity historically, more than 90% of the time with the preoperative plan being able to achieve that goal within 5 degrees. And part of this, I think, is the nature of the cage and the fact that we've got a good congruent cage in there. Part of it is also, I think, the process of preoperative planning. And quite honestly, if you're looking at your segmental alignment, you're more likely to hit that. If you know what your goals are, you're more likely to hit those goals. This is a study that I think is really useful. Going back to the Levesque study, this study was actually done by Benny Dahl and the group in Denmark. And what they showed is, again, short segments fusions for degenerative pathology. In a lot of instances, especially the subset of patients who are hypolordotic from L4 to S1, but a subset of patients who are hypolordotic ending up with a maldistributional lordosis. So ending up with L4 to S1, we think about that being at least 2/3 of our total lordosis, ending up with L4 to S1 being hypolordotic. And in that subset of patients, the 1-year revision rate, this is lumbar degenerative pathology, 1-year revision rate was, in this case, 20%. In another series that Min-Ka did out of Switzerland, the 2-year revision rate was almost 50%. Actually, it was over 50% in patients who were poorly aligned. So even short segment fusions, this ought to be something that ought to be pretty reliable, having these malaligned. So the Aprevo people looked at, again, the shorter segment lumbar degenerative cases, and this, again, Rodrigo Nicolau was the lead on this. But looking, I think what's especially important is a subset of patients who start off hypolordotic from L4 to S1, improving that to a normal distribution index with the patient-specific cages. So I think this is pretty compelling evidence that with these patient-specific cages, even in degenerative pathology, we can do well, and especially from L4 to S1. Most of those were A-lifts in this series rather than T-lifts. Getting more into adult deformity surgery, again, Chris Ames was the lead on this, and Justin Smith, and some of the people who were part of that original paper I showed you were more than 50% of the deformity cases did not achieve their alignment goals within 10 degrees. In this case, a dramatic improvement. Again, deformity cases, but much improved. More than 50% of the time, patients were within 5 degrees compared to being outside of 5 degrees. So using the same measurements, the personalized interbody implants reduce the rate of posterior malalignment by half. So again, pretty compelling data. There's a COMPASS registry that the Aprevo people have actually sponsored. This has now got over 300 patients in it, looking at patients with degenerative pathology as well as deformity. And now the follow-up is 2 years for, I think, 360 or so levels. And the reliability of getting lordosis within 5 degrees of the intention is now more than 90% with the A-lifts. What about end plate conformity. And again, I was a bit critical of some of the stock cages. And one of my criticisms is that the axial congruity with the end plate leads to subsidence and leads to an unreliable restoration of lordosis. So that mismatch creates gaps, the potential for subsidence, potential for non-union. And with good congruity, that really does matter. And the evidence to this is both with regard to stress on the end plates, and we show this biomechanically, that a cage with good end plate congruity has less stress to the end plates, so less likely to subside. And also, this is looking at the cervical spine, again, less subsidence, 40 times less incidence of subsidence with good congruity. And this is what we want to avoid. This is a case that I revised recently, a patient with a L5S1. In this case, it was an isthmic spondy, and somebody, kind of tried to bang in the cage, I think probably without an adequate release, ended up fracturing the sacrum. Again, what were the risk factors here? No pelvic fixation, poor end plate congruity, trying to bang in a triangular cage into a space that's non-congruent, and this is the kind of failures that we see really quite often. And I think perhaps both better end plate preparation as well as maybe better cage congruity might have avoided this early problem. A lot of evidence, again, from the basic science, mechanical properties, that with good congruity to the end plate, we can get a better distribution of end plate loading, so less likely to get subsidence over time. And fundamentally, what this does also is by having a good surface area of that cage, we can reduce the load on the rods. So in deformity surgery, one of the major reasons for revision, about 38% of these cases were revised for rod fractures. And what has that led to? Well, now using multiple rods. And I can tell you how many of our deformity cases now have got satellite rods, accessory rods, up to 6 rods across this. I don't think that's the answer. I think a lot of the reason why we need supplementary rods, in my 3-column osteotomies, I'm using satellite rods. In my patient with a big trunk shift, I'm using an accessory rod, typically a kickstand. But I think we're using too many rods to make up for bad carpentry. And the stress shielding that results from multiple rods, I'll show you why I think that's a problem. So with good interbody cages, that 38% revision surgery rate has gone down to less than 2%, and I'll show you data on that. But specifically, with good interbody congruity, we're seeing a reduction of the strain on the posterior rods by about 30%. And again, this is what we want to avoid, is those posterior rod fractures with good end plate congruity. This is another paper specifically looking at stock implants and high rates of revision surgery at 1 year, 10% rate. At 2 years, we've seen rates of 40% or more from mechanical complications. So looking at, again, the COMPASS registry, so this is a group of patients with both deformity and degenerative pathology, but the rate of reoperation at 1 year from 10% with stock implants to less than 2% in patients with the congruent implants, and this is showing that graphically. So dramatic improvement in the rate of mechanical complications. So I'll spend my last few minutes here talking about how does this actually work in my practice. So what happens is, in most of my cases are about 90% revision surgeries. I've got a preoperative CT, and you're using SPECT scans, but how often, Jens, are you having a CT scan on your patients preoperatively?
Almost always, for all reconstructive surgeries, for all disc arthroplasties, for all anterior neck surgeries. I like CTs.
Yeah, I really find that looking at the frame, and specifically, I think those of us doing more complex surgery, doing a lot of CTs, they've got technology soon where they can actually do this off of an MRI scan. But right now, from a preoperative CT, I'll be booking some patients typically about 3 months after surgery. So most of these are elective. But they could do in less than 10 days, they can actually design a patient-specific cage. They've got A-lifts, which is mostly what I do, direct lateral cages as well as T-lifts, and design it that's really perfectly congruent with the end plates. And what's interesting about this is that my cages might be different than Jens's. So for example, what I specify is that my goal is to get 35 degrees of lordosis from 4 to 1 on just about all the cases. My cages are always a minimum of 7 millimeters of posterior height. So when I first started this, I got a couple of cages that were, you get 3 options, but mine are minimum of 7 millimeters posterior height because I'm really trying to get that indirect decompression, and then perfectly congruent with the end plates. So this is a process that's sort of done in an automated way. Preoperative imaging, the Carlsmed people will take a look at, hey, I booked an ALIF. They'll take the CT scan, plan an implant, and then send it to me. And they'll say, hey, here's according to your plan. So they don't influence the plan, but you're thinking about doing an ALIF from L3 to S1, and here's cages that we can design. And I just check, do I want to use these or not? And there's some cases, so you'll see in my series, there's some cases where I said, no, I don't want to use it. And typically that's because I said, well, instead of doing an ALIF from 4 to 1, I'm going to do a PSO, or I'm going to do some other surgical approach. And but most of the time, I'll say, yeah, thanks for making that plan, and that's consistent with what I want to do. And this is just an example of what I might see for a lumbar degenerative scoliosis, where I might do L4 to S1 or L3 to S1, and they'll actually show, here's the reconstruction of the alignment that we can expect. And then this is one where I went 3 to 1 front and back. And what I want to show you here, I think I'll show you maybe on the next, maybe I'll show it better on the next one. But what you're seeing here pretty reliably is the absence of end plate subsidence. You're seeing good congruity to the end plate with the implant. And I think I'll show you better on the next one, is a really nice restoration of foraminal height. So here's a different case. This is a patient with a post-laminectomy deformity. You see advanced degenerative changes from 3 to 1, some stenosis across the lumbar spine. Looks like stenosis goes up to 2, 3. And again, anytime I see vacuum discs, you're going to be thinking about, well, I'll get that lordosis back with an intradiscal osteotomy. This is a 68-year-old patient with some coronal, primarily sagittal plane deformity. And this is one where intraoperatively, I think there's 2 things to notice here. Is one, the congruity of the end plates with the devices, right? These are really big footprint devices. They cover the entire end plate. And in general, I'm getting the cages back pretty much towards the PLL. But what I want to show you is the improvement of the posterior disc height, right? So you see the 4.5 and 5.1 level, right? That T1 parasagittal being such tight foraminal stenosis, and how well I'm able to indirectly open that up by getting a cage posteriorly, having a minimum of 7 millimeters posterior height. A lot of this has to do with making an adequate release. But once I make that release, getting something in there that fits congruently has been my experience, has been, I think, best with these cages. And then this, I guess for some reason I went up to T10 on this. But what I want to show you, I'm not sure if this is projecting very well, but this is actually a different case. But L3 to S1, T11 or T10 to S1 posterior. And on the right side, it's not projecting that well, but on the right side, what I'm trying to show you is the patient's got 6 rods, and despite having 6 rods, there's still 4 of the rods fractured, right? And the point being that I think with good anterior column support, good end plate congruity, that's what's going to take the strain off the rods better than putting multiple rods in. And so so here you see it better, right? Somebody with multiple rods, I guess there's 5 rods in there, still has failure of fixation, broken iliac screws, broken rods. I don't think multiple rods are the answer. I think the answer is putting in good interbody devices, having good congruity, and that's what takes strain off the rods rather than multiple rods. So overall, what I think is the advantage here, getting predictable alignment, and that's been shown with the COMPASS registry, both in deformity as well as degenerative pathology, and I think reducing the risk of revision surgery. What we're seeing so often now in our larger registries is rod failures, and I haven't seen a rod failure with the Aprevo interbody cages. So that's my overall experience. And what I cut out of this, the last time I was here, I talked a lot about precision medicine and being patient specific. And I think that this is something we're seeing a lot in the cancer world. We're seeing this throughout pharmacologic world, is understanding the patient's genomics, radiomics, proteomics, and really trying to apply these patient-specific approaches to our surgical planning. And I think that this is a great example of using precision medicine, precision applications to reduce risk for our patients, also for us as surgeons, and also to reduce the cost of care overall. So I don't know if we have some time for discussion,
Sure.
but those are the main points I wanted to make somewhat briefly.
Thank you. Beautiful talk. So logistically, I'm going to ask something there. So you're obviously a superb surgeon. I'm still not sure that you need personalized equipment, implants, because I could give you some stock stuff and you'd make it just look as beautiful. But logistically, I can see a huge advantage to have highly dedicated implants for a patient and not schlep in the big, massive, weighted cases with multiple implants, either on a trolley cart, packaged sterilely, or on the field. So I see that to be a huge advantage. How often does it happen that the customized implant does not fit and you want ersatz? I noticed that in rods. Now we looked at these pre-contoured rods, and they have a pretty high rate. This is a different topic, but related, of needing a rebend or another implant. So how often does it happen that these cages actually fit? How often is the rejection rate of those?
Yeah, really important question. Is first of all, I think the burden on our materials management people for bringing in multiple trays is we had a case recently. There were 24 different trays. You know, I've got 3 separate tables in the back of the room. Whereas with these precision implants, bringing in one tray, they're pre-made, pre-fit, and I can tell you in my experience so far, I think about 30 cases using the Aprevo, and I still do sometimes use stock implants, primarily when I don't have a preoperative CT scan. There was one case, there was an isthmic spondy, a dysplastic spondy, where I actually recontoured the end plate. So I took off some of the bottom of L5, recontoured the end plate. I didn't like the congruity because the pre-made cage was actually congruent with the dome sacrum, and when I recontoured it, I ended up using a stock cage. But that was really the only time where I've actually not used my pre-made cage. And again, I think the congruity is impressive. My reliability, what I've seen some problem with is being off-center with a stock cage. Is I've occasionally, especially 5'1", been a little bit off the midline. And I've actually had one case that I had to revise for foraminal stenosis because the cage was off the midline. In this, with the precision cages, they almost kind of snap into place. And my reliability of being midline, center, especially at 4.5, is much higher. And I'm getting a much wider footprint.
Then the next thing is, so expandable devices, usually titanium devices, have really hit home hard. How about individualizing a patient's anatomy or anatomic requirements by expanding the cage in a differentiated fashion? So you create your own device in vivo as you're doing the surgery. So expandable cages versus a pre-contoured rigid cage. Advantages, disadvantages?
Well, certainly, in a T-lift, you were showing a lot of expandables, and I think in a T-lift that could be really useful. Maybe some differential expansion. I think the critical notion, be it anterior or posterior surgery, is the release, right? Is your cage can do a lot more work if you do an appropriate release. In terms of an expandable anterior cage, I haven't really seen one that's been reliable there. I know that there was a device, I forget who made it, where you put in the end plates and shove in
Stack them, yeah. Shards. Dr. Oskurin did a lot of expandable lateral antibodies when he did a lot of those. So they have laterally expandable X-lift devices or far lateral devices.
I've also used the lateral expandable X-lift. It was one of them that was taken off the market because it subsided.
Yeah.
But in general, I think it's certainly with the A-lifts, I don't have an expandable A-lift, and in my hands, doing the release is most of the work. And so rather than trying to rely on the interbody to actually create that, is I'm doing a release and then I'm filling the gap with congruity. I think that's what the Aprevo does really well.
So without mentioning the healthcare systems, but what's the cost differential? So how much of a premium does a custom-made, individualized, 3D printed, I assume, device give the patient / the healthcare system in this era of commoditized spine surgery?
Yeah, this is a really important consideration is what's the economics of this? And these cages are more expensive than most of the stock cages. But where it comes back from the hospital perspective is we do a lot of work at UCSF with regard to understanding what the contribution margin is. So if we're going to bring in something new, making sure that we're actually improving the contribution margin. So it's not just the cost alone, but it's what does the hospital get back. So up till last year, these cages actually had an NTAP payment. So based on the preclinical data, based on the biomechanics, rod subside, reducing stress on a rod, reducing revision surgery, CMS approved a new technology added payment that was dramatic. And I'm not going to quote the numbers, but it was essentially reimbursement per level was twice as much as the cage, just for using the cages. Now that's transitioned, and I'll let the Aprevo people maybe talk for those who want to use these cages. Now what happens is that there's an upcoding of the DRG. So your surgical fee is the same. And having said that, the surgeon's work is pretty much the same. So I'm not expecting to get more money for these cages as a surgeon. But the hospital does very well. And the way that the hospital makes money on this is that there's an upgrade from whatever the DRG code is. It goes to either CC or it's already a comorbidity complication to an MCC. So it gets upgraded by one level. And that ends up, from the hospital perspective, actually more than covering the differential cost of the implants. So if you're interested in contribution margins for the hospital, if that's something that you're part of, and as Chief of Spine at UCSF, that was a big part of what I had to be accountable for in the past. And that's something that the hospital does well with these cages.
Great. We'll have to come to a close. As always, it's been so much fun to have you here. Your contributions on the big picture can't be overstated, but here, even in each case and the vignettes, it's just a treasure to have you here with us and contribute and share your wealth of experience. Thank you, Sig.
Thanks for having me. It's nice to be here.
Thank you for having
Yeah, thanks for having us. Appreciate it.
Let's do a little group picture, and I'll have to run.
That's so cool.